common diagnosed cancer for men and women. And for 2021, approximately 104,000 new cases of colon cancer are expected, and about 45,000 new cases of rectal cancer are expected. That puts the lifetime risk of colorectal cancer is around 4% for men and women. And it's an important thing to remember, and I'll try to reinforce this several times, that it's one of the cancers that we can prevent through screening and removal of polyps before they turn into a cancer. So going over some survival data for colon cancer, in the United States, colorectal cancer is the second leading cause of cancer in men and women. SEER data, which stands for Surveillance, Epidemiology, and End Results, is a National Cancer Institute program that tracks cancer statistics in the U.S. It looks at a relative survival rate, which compares people with the same type and stage of cancer to people in the overall population. So 5-year survival, for example, means that people that have cancer are on average about 80% as likely as people who don't have that cancer to live for at least 5 years after being diagnosed. As far as survival data with localized, they group this as no sign that the cancer is spread outside the colon or rectum. For regional, the cancer has spread outside the colon or rectum to nearby structures or lymph nodes. For distant, the cancer has spread to distant parts of the body, such as the liver, lungs, or distant lymph nodes. And these numbers are based on people diagnosed between 2010 and 2016. As you can see, basically survival goes down with advanced disease. It's important to remember that this type of data is based on, previous data that was collected. It doesn't reflect what will happen in any particular case or patient. All patients' cancers are unique. And then also to remember, treatments have improved over time. So the survival data is, dated. Sorry about that. I'm kind of a Zoom newbie here. So what causes colorectal cancer? It has 3 main pathways. There's the chromosomal instability pathway, the microsatellite instability pathway, and the methylator phenotype. Colorectal cancer is a multi-step process and entails the accumulation of genetic changes over time. Chromosomal instability is the most common and kind of classic form of genetic instability in colorectal cancer. It accounts for about 75% of all colorectal cancers. This is kind of what's been thought of as the traditional adenoma to carcinoma sequence. Clinically, these cancers tend to be located in the left colon, have a male predominance, and develop later in life. Microsatellite instability pathway. This results from faulty DNA mismatch repair function, or MMR. Inherited mutations in one of the DNA mismatch repair genes, which are MLH1, MSH2, MSH6, and PMS2, result in Lynch syndrome or hereditary non-polyposis colorectal cancer. This accounts for about 3 to 5% of all colorectal cancers. It's an autosomal dominant inherited syndrome that has associations with other type of cancers, such as endometrial cancer being one example. Then towards the bottom, kind of in the smaller print, the methylator phenotype. This results from hypermethylation of a DNA promoter region, and this affects the mismatch repair gene MLH1. Unlike the chromosomal instability pathway in which the precursor lesions are adenomatous, the precursor lesions in the methylator phenotype are serrated polyps. These cancers tend to develop in the right colon at an advanced age and are more common in females. Most colorectal cancers are sporadic, with only about 5 to 10% arising with a known hereditary syndrome. Some modifiable risk factors are just kind of basic common sense, healthy lifestyle choices, watching your weight, being more active, avoiding excessive alcohol use, and that's 1 per day for women and 2 per day for men, and avoiding smoking. Diets high in red meat and processed meats have been linked to increased colorectal cancer risk. Increase in calcium and vitamin D intake may have a role, but more research is needed. A meta-analysis of randomized trials in the Lancet Journal in 2010 revealed that the use of aspirin for approximately 5 years reduces incidence and mortality due to colorectal cancer by 30 to 40% after 20 years of follow-up. Some non-modifiable risk factors include a personal or family history of colorectal cancer, especially first-degree relatives, a history of inflammatory bowel disease, such as Crohn's or ulcerative colitis, period. These chronic inflammatory conditions can lead to dysplasia or abnormal changes in the lining of the colon or rectum that can ultimately turn into cancer. Inherited syndromes such as FAP or familial adenomatous polyposis or Lynch syndrome. African Americans have the highest colorectal cancer incidence and mortality of all racial groups in the US. Ashkenazi Jews also have one of the highest colorectal cancer risk of any group in the world. And then type 2 diabetes has an increased risk, with those patients usually having multiple risk factors such as being overweight and less physically active. And then, of course, non-modifiable risk factor of age. The older you are, then the higher risk of cancer. So early colon cancers are often asymptomatic, which kind of underscores the importance of routine screening. 7 out of 10 diagnosed have no symptoms. Presentation includes blood in your stool, which is never normal, and that can be bright red blood, hematochezia, or dark blood, melena. Abdominal pain is often poorly localized, and it can sometimes be colicky when cancer develops luminal narrowing. Also, weight loss, anemia from blood loss, and then change in bowel habits, diarrhea, constipation, mucus in stool, and a change in the caliber of stool, especially for lower cancers and left-sided cancers. The American Cancer Society decreased the screening age from age 50 to 45 in 2018. The United States Preventative Task Force endorsed starting at age 45 as well as in 2020 for people at average risk. Average risk individuals include people with no personal history of colorectal cancer or adenomatous or serrated polyps, no family history of colorectal cancer, no personal history of inflammatory bowel disease, no confirmed or suspected genetic cancer syndrome such as Lynch or FAP, no personal history of radiation to the abdomen or pelvis to treat a prior cancer. Overall, colorectal cancer has been on the decline with the disease rising sharply in those younger than age 50 recently. As you remember, Chadwick Boseman or Black Panther, he recently died, and this has brought some attention to younger people that have had colorectal cancer. And he was diagnosed with stage 3 colorectal cancer in 2016. Data from the Centers for Disease Control and Prevention show that colon cancer diagnosis among patients aged 20 to 49 increased nearly 2.7%, and deaths increased 1.3%, from 2012 to 2016. These rates declined more than 2.5% among patients 65 and older. By 2030, 10% of colon cancers and 22% of rectal cancers diagnosed in the US are expected to be in patients younger than age 50. As far as screening people and how long to screen people, people in good health with a life expectancy of more than 10 years should continue regular screening through the age of 75. Screening people aged 76 to 85 should be individualized based on the patient's preference, life expectancy, prior screening history, and overall health. If someone has a first-degree relative with colorectal cancer, you should start screening 10 years prior to the age of diagnosis. If someone has a genetic syndrome such as Lynch or FAP, they should start much younger in life as well, period. Overall, screening tests can be divided into stool-based tests and visual exams. So blood vessels and larger colorectal polyps and cancers are often fragile and can be damaged by passing stool, resulting in hidden or occult blood in the stool. The guaiac-based fecal occult blood test detects blood in the stool through a chemical reaction. Different kits will have different instructions, but it will entail collecting samples from consecutive bowel movements. Stool checked from one stool sample during a rectal exam is not enough for proper screening. There are also some dietary restrictions, such as avoiding vitamin C supplementation, citrus fruits, and red meat prior to testing, along with avoiding red meat intake. You should also avoid NSAIDs for 7 days prior. One advantage is that this test can be done in the privacy of your home, no bowel prep. But as you can see, there's some drawbacks with dietary and medication restrictions, along with compliance and processing. If you choose to offer this test, it must be done annually, and a positive test should be followed with a colonoscopy. Another stool test option is a FIT test or fecal immunochemical test. This directly measures hemoglobin in the stool and does not require altering your diet or medications. It only measures human blood. It also requires one sample and is more sensitive for bleeding from the lower GI tract. This test should be done annually as well, and if there's a positive test, it should be followed by a colonoscopy. Advantages are the same as fecal occult blood testing, and they can be done at home and without a bowel prep. Another stool test option is multi-target stool DNA or FIT DNA, also known as Cologuard. This tests for DNA changes as well as blood in the stool. Cologuard is 92% sensitive for detecting colon cancer and about 69% sensitive for detecting advanced colon polyps. Advantages are it can be done in the privacy of your home, no drug or dietary restrictions, and only requires one stool sample. If this test is positive, the patient should have a colonoscopy. One question regarding the use of Cologuard is that if I have a positive test, but a patient has a negative colonoscopy, what do? So Cologuard has about a 13% false positive rate. In my personal practice, I will usually treat the internal hemorrhoids at the time of colonoscopy with rubber band ligation in the event that trace blood from the hemorrhoids was the source of the positive test. Otherwise, asymptomatic patients with a positive Cologuard and a negative high-quality colonoscopy do not warrant upper endoscopy or radiographic imaging to detect non-colonic cancers based on current guidelines by the U.S. Multi-Society Task Force. Other options include to repeat the Cologuard or to perform fecal occult blood tests in several months to see if it was a false positive. This test should be covered by most health insurance companies, including Medicare, with a maximum cost without insurance around $649. Screening also includes a colonoscopy, which is regarded as the gold standard. As I mentioned before, genetic changes that ultimately lead a polyp into turning into a cancer, with a colonoscopy having the distinct advantage of removing the polyps before they turn into a cancer. Recommended goals for a colonoscopy quality include a cecal intubation rate of greater than 95%, so that you make it all the way around to the right side of the colon. And that should be 95% for screening colonoscopy. You should have a goal of greater than 90% for all other colonoscopies. An adenoma detection rate of greater than 30% in men, as well as greater than 20% in women. Withdrawal time, how long it takes for you to pull the colonoscope out from the cecum, should be greater than 6 minutes. And then you should have an adequate bowel prep in about 85% of all your colonoscopies. Some disadvantages of a colonoscopy is the bowel prep. Patients commonly say, I don't want to drink the big jug of nasty prep. But nowadays, most preps are low volume, drinking anywhere from 8 ounces of prep followed by 16 ounces of clear liquid. We now employ a split dose regimen where the patient will take 1 dose the day before colonoscopy and the other dose on the day of colonoscopy period. This has been shown in studies to be more tolerable and to obtain better cleaning in the colon. Other disadvantages is the patient will have to miss some time off work. Risk of colonoscopy include bleeding as well as perforation. A number of large studies have reported hemorrhage in the 1 to 6 per 1,000 colonoscopies, with a rate of perforation reported in large studies to be around 0.3% and is generally less than 0.1% in most studies. Sigmoidoscopy is also an option when combined with a fecal occult blood test or a FIT test. Disadvantages include you still have to do a bowel prep, and there's a chance that you will miss right-sided colon cancers. If a sigmoidoscopy is positive and that you remove a polyp or find a cancer, the patient still needs to be followed up with a colonoscopy. And I've personally never used this in my practice, but it is an option. CT colonoscopy or virtual colonoscopy has advantages, including no sedation. The patient still needs to undergo a bowel prep, and they need to be informed that there will be some discomfort with air and CO2 insufflation to expand the colon during the test. Positive findings also require colonoscopy. This test can be done every 5 years. Some drawbacks is that it may not be offered at all facilities. So which screening test is the best? This graph demonstrates sensitivity for the specific tests we have discussed with detecting adenomas of various sizes and colorectal cancer. As you can see, colonoscopy has the highest rates for various sizes of adenomas and sensitivity for detecting colorectal cancer. So if your patient has been found to have colon cancer, the next step involves preoperative staging. These recommendations are from the NCCN guidelines, include blood work with obtaining a baseline CEA level. CEA, or carcinoembryonic antigen, is a protein that's found on the surface of many types of cancer cells. It has a low diagnostic ability to detect primary colorectal cancer due to significant overlap with benign disease and low sensitivity for early stage disease. This should not be used as a screening or diagnostic test for colorectal cancer. CEA levels do have a prognostic utility in patients with newly diagnosed colorectal cancer. A CEA level greater than 5 has a worse prognosis stage for stage than those with lower levels. Elevated preoperative CEA levels that do not normalize following surgical resection imply the presence of persistent disease and the need for further evaluation. A rising CEA level after surgery implies recurrent disease and should prompt further workup. The patient should also undergo a CT chest, abdomen, and pelvis with IV and PO contrast. Options for contrast allergy include various MRIs. PET CT is also not routinely indicated. The patient's pathology should also be reviewed with MMR or microsatellite instability testing to evaluate for Lynch syndrome. Staging for rectal cancer is basically the same, other than you need a pelvic MRI with a rectal cancer protocol. This is extremely important to evaluate the circumferential resection margin, which will play a role in operative planning, as well as the decision for treatment prior to surgery. This can also evaluate for lymphadenopathy, as well as involvement of nearby structures. Options other than an MRI include an endorectal ultrasound, which may be more sensitive for T1 and T2 rectal cancers, but has limitations with bulky cancers and stenotic cancers. Rectal cancer is also different in that in the recent years, there's been much more emphasis on a multidisciplinary approach involving a radiologist, pathologist, oncologist, and surgeons to come up with a game plan prior to proceeding with a treatment course. Staging for colon and rectal cancer involved the T&M staging classification, which includes T, or the thickness of the tumor, N for lymph nodes, and M for metastasis. Broad strokes include stage 3 with positive lymph nodes and stage 4 with metastasis. Treatment options for colon cancer include removal via endoscopy or surgery. Rectal cancer is a little different in that, based on preoperative staging and imaging, as well as multidisciplinary evaluation, some patients will be recommended to undergo neoadjuvant treatment with a chemosensitizing agent and radiation, and that's to help decrease local recurrence in the future. There's also a strategy, recently total neoadjuvant treatment, where patients undergo systemic chemotherapy up front, followed by neoadjuvant chemoradiation prior to surgery. Follow-up, I still to this day and recommend checking in with the NCCN guidelines every so often to make sure that you're having the most up-to-date follow-up and following current guidelines. For colon and rectal cancer, a colonoscopy will be recommended 1 year after surgery unless a complete colonoscopy was obtained prior to surgery. A colonoscopy recommended in 1 year, but sooner if you were unable to get a complete colonoscopy. For example, if you had a stenotic lesion and you were not able to get the colonoscope to see the remainder of the colon, they should undergo a colonoscopy sooner than 1 year. Otherwise, you see patients every 3 to 6 months for 2 years, followed by every 6 months for a total of 5 years, obtaining blood work, CEA levels, CT chest, abdomen, and pelvis. As mentioned before, rising CEA levels should prompt further evaluation. Some resources I use routinely include the NCCN guidelines, American Society of Colon and Rectal Surgeries practice parameters, and American Society of Gastrointestinal Endoscopy. Thank you for letting me talk about colorectal cancer. It's a very broad topic with many of these different facets being a talk in and of themselves, but I just tried to paint broad strokes to go over a little bit of everything. Hopefully the biggest takeaway from this is to encourage your patients to get screened. We can prevent a multitude of colorectal cancers if we remove the polyps prior to them progressing. I've heard some people say the best screening test is the one that the patient will do. So encourage your patients to be screened. And if there's any way I can help you, I'm always glad to talk to you and help you any way I can. So that's the end of the talk, and I appreciate it. Once again, I am a Zoom newbie, so I hope I don't mess anything up, pushing buttons or anything else.
Thank you, Dr. Bailey. Yeah, I think you did a wonderful job. Again, just a reminder, if you'd like CEs or CMEs, to contact me, Tammy Ramsey, at tramsey@hmh.net, and I'll be glad to take care of things from there. And I guess that does it for today. So if you have any questions for Dr. Bailey, anyone have any questions? We've got a few more minutes. Does insurance cover at 45 years of age, Dr. Bailey?
I tried to nail this down prior to this talk, but you never can get a straight answer. All insurances are different. I would say that most insurances are going to have to start doing that, since the American Cancer Society and the United States Preventive Task Force are now recommending age 45. But I'm sure it'll be a fight for some.
Anyone else? Well, I think that concludes our program for tonight. We thank you all for joining us, and we will see you next month. Oh,
all right. Thank y'all.
Thank you. Bye-bye.